Hello friends and welcome back to Dr. A. Sajid. Today in our series we'll be talking about evidence-based medicine. In the last video I talked about how important it is to follow medicine according to guidelines so that we can become doctors who are confident in their decisions because they always have an evidence-based approach to their patients. Recently, I came across a very interesting evidence-based medicine article on the use of fecal calprotectin. Now, in clinic, there's a lot of times when you tend to go and come across abdominal pain with change in bowel habits. And the NICE guidelines suggest that anybody who's less than 60 years of age and has abdominal pain with change in bowel habits, then the best way to go forwards would be to do a fecal calprotectin. But that fecal calprotectin will only be used if we're not suspecting something sinister like cancer. So if they've got alarming red flag symptoms like weight loss or loss of appetite or fatigue or malaise, then we'd obviously want to go forwards with a fit test or a gastro referral to rule out cancer. But if they were to not have those red flag symptoms and you're perhaps confused between irritable bowel syndrome and inflammatory bowel disease, then evidence-based research this time has just come down with the use of fecal calprotectin, which is a protein that's defecated in the poo, and the fecal calprotectin has a very nice and high negative predictive value. So for example, take it this way, that we've got a patient who comes with tummy pain, has change in bowel habits, and we're thinking along the lines, is it IBS, is it IBD? If we were to put it down as irritable bowel syndrome, that's a diagnosis of exclusion, which basically means that it would need thorough investigations like colonoscopies and fit tests and various gastro referrals to make that diagnosis. And in general practice, if you were to think back and you think, perhaps doing some test would help at the end of the day, I think that's fecal calprotectin, because the negative predictive value of the fecal calprotectin is very high, which basically means that if it's negative, it rules out IBD very well. The specificity kind of varies with the amount that you see on fecal calprotectin. So if it is greater than 50, it is less specific because the fecal calprotectin is released in any inflammation out there. So even if it's infective colitis or at the end of the day cancer, if there's some infection going on or diverticulitis, it would come back as positive. So in fecal calprotectin, if it's negative, we should be very sure that it's not IBD, and we can lean towards IBS a lot more. If it comes back positive, it gives us a good motive to investigate further and perhaps a referral to the gastroenterologist. In terms of how it comes back positive, most of the guidelines over here suggest using 100. So they suggest that a value of between 100 and 200 is equivocal. So that would basically mean we'd need to repeat the test. But greater than 200 would need an urgent referral to gastroenterologist. In short, evidence-based medicine has helped inflammatory bowel disease distinguish from irritable bowel syndrome using the test of fecal calprotectin. If the fecal calprotectin is negative, because it has a high negative predictive value, it rules out IBD quite nicely. And if we're not thinking along the lines of the sinister causes of cancer, then we do fall into IBS a lot more confidently. So irritable bowel syndrome becomes the most favorable answer. If it comes back positive, which is greater than 200, it's not quite specific, but it does give us a pathway to go forwards in, and we can always go forwards with an urgent gastroenterologist referral to rule out inflammatory bowel disease. If it comes out between 100 and 200, it is hard to distinguish whether it's positive or negative because of the specificity. So that's the best way to go forwards with that would be to repeat the test again. So that is my today's episode talking about evidence-based medicine making our clinical diagnostic skills, far more reliable and far more based on guidelines. If you've enjoyed it, let me know. I'll be doing a series where I talk about the evidence-based practices. I'll be doing a series also where I'll be talking about the 2 week wait referral. So if you were to see a patient, what is the red flags where you'd want to go to the specialist? And then we'll be talking a little bit for the general public with um with a more with a more with a less complicated approach to most of our topics, so that the non-doctor people on our channel can also understand. So if you enjoyed this if you enjoyed this video, if you liked the information I sent forwards, don't forget to like, subscribe and comment on my channel. Have a nice day. This is Dr. Sajid. Bye.